nurse practitioner and manager, coordinator of the Structural Heart Center here at Sarasota Memorial. I'm going to talk today about aortic stenosis. I've been a nurse practitioner for over 25 years, and I've worked for the past 7 years in structural heart. Before that, did interventional radiology. Before that, I did open heart surgery as a nurse practitioner, worked with a surgeon. So aortic stenosis is a very common disorder of the valves, one of the valves in your heart, the aortic valve. Valves in your heart, as you can see here, allow unidirectional flow. That is one-way flow of the blood in your heart to pump from your lungs and then from the left side of your heart to the rest of your body. The right-sided valves are called the tricuspid and pulmonic valve, and the left-sided valves are called the mitral and aortic valve. Most disease processes as we age occur in the mitral and aortic valve. I like to say that the mitral valve here looks like a big smiley face, and the aortic valve is a 3-leaflet valve that leads from the aorta out to the rest of your body. And as you can see here, as blood goes through the valve, it goes up to your head through these 3 vessels, and then down to the rest of your body through your main aorta. This is a depiction of the left ventricle showing a normal aortic valve that opens all the way, and blood that's pumped with each heartbeat comes out the left ventricle and through that aortic valve to the rest of your body. As you can see here, it's wide open, there's no disease process. However, in a stenotic or narrowed heart valve, you can see that there's calcium buildup, and the valve doesn't open, the leaflets of the valve doesn't open, and it doesn't close properly. So that causes aortic stenosis and aortic insufficiency. Over time, the left heart has to work very, very hard to get blood through that narrow opening. And that causes this left side of the heart to get thicker, like any muscle that works hard. The muscle will get thicker, and eventually that can lead to heart failure. So when we talk about aortic stenosis, this is a true depiction of the calcification of the valve. That calcification is like little rocks on the valve itself. And there are some cardinal symptoms of aortic stenosis. One is angina, which is chest pain that's not relieved, which is not caused by coronary artery disease, and is usually relieved by rest. More commonly, though, we get symptoms of congestive heart failure, and that is symptoms of shortness of breath, especially shortness of breath when you exert yourself. Going up a flight of stairs would have been easy a year ago, and now you have to stop 2 or 3 times going up the stairs. So we call that dyspnea, or shortness of breath on exertion. Unable to lie flat, especially at night, when you have to increase the number of pillows you sleep on. So we ask patients, how many pillows do you sleep on? And if they say 2 or 3, that's one of the signals that we have that they may have worsening congestive heart failure. If someone wakes up in the middle of the night with shortness of breath, so they're laying flat, then all of a sudden they pop up and can't catch a breath and have to sit on the side of the bed. We call that paroxysmal nocturnal dyspnea. So they get short of breath at night and have to sit up. Or they have fluid in their lungs. So people have a cough, a nagging cough. They have swelling in their feet or legs, chest pain, palpitations. Those are all symptoms. Another cardinal symptom of aortic stenosis is syncope. That's a fancy word for fainting or near fainting. And the reason for that, if you think of that narrowed opening, the valve doesn't allow the blood to be pumped up to your head. So if you get up suddenly, you get very lightheaded or woozy, or people can just suddenly faint because there's not enough blood flow going to the brain. There is sudden death that can occur because, again, no blood going to the coronary arteries through this narrowed valve. It is very rare if people don't have other symptoms. So I don't mean to scare you, but it has been reported. There is also some subtle signs like a decrease in exercise tolerance. And we always ask patients, how do you fare now compared to what you were 6 months ago or to a year ago? And if they say, well, I had a patient the other day who said, well, I used to be able to do 5 minutes on the treadmill without getting short of breath. However, I can only do 2 minutes now without getting short of breath, so it's getting worse. Oftentimes people have fatigue. I'm tired all the time. He just wants to sleep all day. He can't do anything besides sit and watch television because just any motion at all will make them short of breath. And we do have a blood test that we use, a fancy name for it. It's called a BNP, and that's where we measure the level of congestive heart failure. So there is a test we can do in the blood to look at heart failure. So aortic stenosis is the most common acquired valvular disorder in developed countries. These are the clinical factors. The older you get, the higher the incidences of aortic stenosis. Being a man, it occurs more in men. People who have smoked, have hypertension, and elevated lipoproteins or cholesterol in their blood have been associated with aortic stenosis. Most people, until they get to a certain point, are asymptomatic. So if your doctor hears a murmur, a funny heart sound, he may get an echo, and we determine what the level of aortic stenosis is, mild, moderate, or severe. If the patients are asymptomatic, meaning they don't have any of those cardinal symptoms, then they recommend an echo every 2 years with patients who have moderate AS because it does progress. If people don't have symptoms, it's a very low mortality, very low rate of death with that. However, once a person develops symptoms that we talked about, the mortality is about 50%. 50% of those people will die within 2 years once the symptoms start. So we are very cognizant and listen to patient symptomatology. So the prevalence is as you get older, the incidence increases. And typically, aortic stenosis was treated with aortic valve replacement. And there are about 50,000 done in the U.S. annually. This is just another photo of a real valve, which shows the calcification of the valve leaflets leading to immobilization or inability to move. It causes a decreased valve opening, and it becomes a burden on the left ventricle, pumping. So once someone has severe aortic stenosis, the 5-year survival rate, if no treatment is done, is very dismal. Compared to other disease processes, you can see that inoperable aortic stenosis only has a 3% 5-year survival rate once it's been diagnosed. So we have a type of aortic stenosis called senile. That means as you get older, you can develop this, and that, again, is another picture. However, there is a congenital deformity called the bicuspid valve. See the difference between the tricuspid and the bicuspid? Bicuspid valves don't work as well as tricuspid valves. And so what happens is they fail earlier. And we see these bicuspid valves in patients age 40. It's usually men, age 40 to 60 is where they present. The traditional treatment for aortic stenosis is open aortic valve replacement, requiring a sternotomy, meaning cracking open your sternum, cardiopulmonary bypass, and a valve replacement with either a porcine or biological valve, or cow or pig valve, or a mechanical valve. Mechanical valves require someone to be on lifelong blood thinner like Coumadin or warfarin. So we, in our era now, we have really suboptimal treatment of aortic stenosis. It's because of a lack of diagnosis. Many physicians and other practitioners will hear a murmur in an elderly patient and just say, oh, you're just old. You know, there's nothing we can do about it. We used to hear these and say, oh, it's just a murmur of senile aortic stenosis, so no treatment in an 80-year-old. Doesn't need it. The symptoms, like I said, are just assumed to be a part of the natural aging process. There's a lack of screening and referral at the primary care level, and the thought was that people are too old for open heart surgery. But it's changed now, so once we've got the internet, we have everybody on the internet, and everyone can look to see what treatment options are available for them. And my patients are the most savvy patients in the world. I'm serious. They're very technically good. So I don't want to get too much into this, but when your doctor does an echo, he's looking for these specific numbers of what aortic stenosis is. And to qualify for a valve open heart or a TAVR, which is a Transcatheter Aortic Valve Replacement, through the leg, it has to meet these criteria of severe. So oftentimes we'll get an echo and they're still moderate, and we'll follow them until symptoms start and their numbers meet criteria. So as you get the pressure gradient goes up, the velocity goes up, and the valve area becomes less than 1 centimeter squared, then that's when they start becoming a candidate for this procedure. I wanted just to mention, this is the echo that we get, and as you can see where that arrow is, that's that rocky stuff that you saw in that surgical specimen. So we see these little rocks that light up as bright white, and we can see that as severe aortic stenosis. So how do we treat it? Well, one of the treatments many, many years ago was thought to be the great treatment forever. It's called the balloon valvuloplasty, which is putting a balloon from your leg up into the aorta, through the aortic valve, and opening the valve, just crushing all that calcium against the wall. However, it was fraught with a higher incidence of stroke, and people, because those calcium bits would go up to the brain and cause a stroke. So we only do that, and they found that when it was successful, it only lasted 6 to 12 months. So the aortic stenosis comes back. I had a patient one time that said, well, lasted a day. So he didn't work for him. But I did have a patient that it lasted 2 years. So, you know, we can't predict how long it's going to last. So we oftentimes use this as a bridge therapy. Say a patient is short of breath, and we don't know if it's his lung or it's his valve. We may do and they're pretty sick, so we may do a balloon valvuloplasty. If they get better with the valvuloplasty, then we know a new valve is going to help them. But if they're the same shortness of breath, we could then attribute it to the lungs. And sometimes we do it just for palliation for patients, just to make them feel better as they're passing away, if you will. So again, what is the treatment for aortic stenosis? Replace the valve. So this is a surgical valve replacement. There is no medicines that we can give to treat aortic stenosis. We do use cautiously treatment for congestive heart failure, like diuretics, ACE inhibitors, beta blockers, that sort of thing. And we use this treatment for hypertension very cautiously, because if we lower their blood pressure too much, they're not going to have that pressure pumping to the brain, and they're going to faint and be more symptomatic. So, how do we treat? We replace the valve. Early on in the 1960s, there was a valve called the Starr-Edwards valve. So it was a unique valve that was a ball and cage valve. Worked very well. However, with technology, we have advanced from a bioprosthetic valve, porcine, bovine, so a pig or a cow, mounted on a step, to a bovine pericardial valve, to a transcatheter valve, which was the first one done in France by Dr. Crivier, and then the Edwards Sapien heart valve, which was approved for commercial use in 2011. And these are just for my edification, when we started putting in commercial, meaning not in a clinical trial, transcatheter valves, and the sizes that are available and when they became available. So we are part of a national registry. Every commercial TAVR center has to be within this registry. There are about 418 sites, and we have different procedures that are in there. As you can see, in 2012, there are about 4,500 patients, and in the 2015, 54,000 TAVRs have been done commercially. So our results here at SMH are above, better than national average. So our 30-day mortality is about 3% compared to the national average of 5.7. Our 1-year mortality, and that is all-cause mortality. I mean, a patient that dies after a year, whether it's from kidney failure, cancer, automobile accident, whatever. So all-cause mortality is about 19%, pretty much equal to, this is after TAVR, Our stroke rate is equal to the national average, and our pacemaker rate is a little higher. It's about 14% on average to need a permanent pacer after the TAVR. So these are the two valves we use here. The one on the right is the Edwards valve. It's called the Sapien 3 valve. It's balloon expandable. It's made out of a cobalt alloy and out of the pericardium, the lining of a cow's heart. The Medtronic valve is a self-expanding valve, which is made out of nitinol and the pericardium of a pig. So we put these valves in, they're transcatheter valves, so we try and put them in through the leg. And what this is telling us, 24 to 14 French is the size of the sheath, the device we put in the leg. So the size of the device has become much smaller, and we can go in smaller arteries. So when we first started doing this, little tiny ladies couldn't have the valve. We'd have to go through a cut in their chest or a cut in their beneath their collarbone. But now that the sheath size, what we put in the leg, is much smaller than when we first started. This is just how a valve is put in. The Edwards Sapien valve, again, is balloon expandable, and the leaflets of the valve itself sit within the annulus, whereas the leaflets of this valve sit above the annulus of the aorta. We do measure the coronary heights. We do a lot of measurements for this procedure. And I just wanted to go through a second of how we navigate toward a TAVR. Like, how do you get a TAVR? Well, first you have to have a referral, whether that referral comes from a cardiac surgeon, whether it comes from your primary care, whether it comes from a cardiologist, or you can self-refer if you want to the TAVR clinic here. But there are many diagnostic studies that are required, and I always tell my patients, okay, I have my hoops ready for you to jump through, because it takes time to get through this process. First of all, you have to have meet the criteria. So we need to have an echocardiogram to see if you meet the criteria. Then there we do all our measurements, which are listed up there. Then a lot of physicians like to have a transesophageal echocardiogram, and that's an echo that's done with a probe passed through the back of your throat. That can measure the size of the valve that we need. A patient has to have a heart catheterization, and that tells us whether or not they have any known coronary disease or blockages in the heart that need to be treated. Then we get a CAT scan, which is a special CTA, which is an arterial CAT scan that shows us your leg arteries to make sure that they're big enough. They have to be at least 5 millimeters in diameter so we can get our devices up there. And so we get a very specific CAT scan to look at not only the annulus of the valve, but the arteries leading up to the heart, and if they're wiggly and we can get up them. So that is important. We get a breathing test to make sure that your lung volumes are adequate. And it is a CMS or Medicare requirement that patients who are going for TAVR evaluation have to be seen by 2 cardiac surgeons. We have a special clinic with the cardiac surgeons that we hold once a week, and we have the 2 surgeons come at the same time to try and minimize the patient's visit time. We do some quality of life testing, and we do a 5-meter walk, and the 5-meter walk tells us about frailty of a patient. It's been correlated. If you can't walk 5 meters in 30 seconds, then you're at a higher risk for them. So then we set a TAVR date. They're usually done here on Tuesdays and Thursdays. And from now we are doing more patients under what we call conscious sedation. That means no breathing tube, no Foley catheter, just IV sedation. And the procedure takes about 30 to 40 minutes. And then we recover in the cath lab recovery room. Our average length of stay here at SMH is 2.5 days. We get these specialized CAT scans. This tells us how much calcium, this white stuff, is on the valve. We measure the valve size. We see how much calcium is on the valve. And it's all very technical. All right, so now I'm ready for the video. We're just going to show a short video of how the valve goes in. This is the Edwards valve. And so we get access through that sheath, and this particular patient is getting a pre-dilatation or a balloon dilatation before the procedure. I would say about 90% of the time we don't do that. You can see the heart jiggling there. We rapidly pace the patient while we do any valvuloplasty or put the valve in. So we remove the balloon through the sheath. The sheath is what we work through. And like we said, it has to be, your leg arteries have to be at least 5 millimeters. This is the valve here, crimped on a balloon. They bring this little nose cone back down into the valve itself. And using X-ray or fluoroscopy and echo, we position the valve in the valve annulus. We go around the curve of the aorta or the arch of the aorta. You can see this calcium. These are your coronary arteries. So we place the nose cone into the valve. It's very tight. And using these special markers on the valve, we put it right in the right place. The physicians put it in. I'm watching. And we can maneuver it to where we want it to go. And the other valve, it has the capability of that we can recapture it if we don't like the way it looks. So this is put in. They'll rapidly pace the heart again, blow up the balloon. The valve foreshortens, has this little skirt on it that prevents paravalvular leak or leaking afterwards. We remove all our devices. And then take the sheath out, and the puncture in your groin is sealed with a special percloser. We sew up the hole in the valve, in the leg, sorry. So there's the new valve working. And you can see that the old valve is crimped along the edges and kind of wallpapered in. And you have a wide open aortic valve. It's wonderful.
Beats the old way.
It sure does.